what's the take-home message from the hypofractionation? I think it is a good treatment. It was shown with very solid data that it can be used successfully. Whether we can use it post-mastectomy or not, the British included mastectomy patients, and it seems to be working. Regional radiation, the British also allowed regional radiation, and it seems to be working. I personally, I have some concerns about that. I need more data to use it in the regional radiation, convenient and cheaper. Now, the other innovation was the partial breast radiation. So for the non-radiation oncologist in the audience, partial breast radiation means very simply, instead of treating the whole breast, you treat just the lumpectomy and with the margin around it. And if you go down in volume, you can afford increase the dose per fraction and finish your treatment in 1 week. And a lot of women love that. So you end up by treating around 25% of the volume of the breast. And the rationale for it is very simple. The majority of local failures occur in the same site. So what's the point of treating the whole breast? And you could go back 25 years ago when surgeons used to do mastectomy for very early breast cancer, and it took time for surgeons to change into, yes, we can keep the breast when we have cancer, and then take the lump out. And still until now, a lot of radiation oncologists, they did not digest yet the partial breast radiation, afraid of not treating the whole breast. But it is working, and I will show you the data. It's very convenient, potentially reduce the acute and chronic toxicity because you are off the heart, off the lung, treating just the spot, and it improves the quality of life. And so that's the principle, that's the hypothesis. So since then, all what you need to do is just put the dose of radiation in the lumpectomy. So you had a lot of ideas. You could do brachytherapy by putting catheters with a high dose rate or low dose rate. You could put a balloon inside. You could do intraoperative radiation with electrons, with low kV photons. You could do 3D conformal or IMRT. You could do anything. Just put the radiation there and spare the rest of the breast. There are exactly around 18 techniques. And so now we have the principle which technique you will use, and we're still arguing about what is the optimal dose and what is the optimal fractionation. So the technique which should be used should be simple, because what's the point of having a very sophisticated technique that only big institutions can use? We have to have a technique which is simple, that any radiation oncologist who used to do 2 tangents on the breast, this person should be able to use the partial breast radiation. Should have less complication, should be less costly, and give better or same results. So what are the phase 3 randomized trials? Starting with the British Target, that's the name of it. It's intraoperative radiation. Patient is asleep, lumpectomy, give radiation, patient is awake, surgery and radiation is done. What better could you have? So this is a low soft radiation, 50 keV. They randomized 3,400 patients, very early small breast cancer. Standard radiation versus this one shot during the patient during the lumpectomy. Of course, some women had bad pathology. After that, they used this radiation, which was 5 gray, delivered at 1 centimeter, which I thought is a little bit low, but that's what they used. And so if the patient is a high risk, the patient receives whole breast radiation. Their data showed that there was a slight increase in local failure in women who received this intraoperative radiation from 1.3% in the external radiation standard into 3.3%, still acceptable here, still acceptable, but I don't know what will happen after 5 years. Will this continue to increase like that, or will just plateau? That we don't know. But there is a slight increase in local failure. Now we move, so that's the British. Now we move into the Italian style, which is, they call it Elliot. It's intraoperative radiation using this linear accelerator, which moves from one OR to the other, and it delivers electrons. Again, designed very simple, whole breast radiation, 50 gray plus 10. versus IORT, intraoperative radiation, delivering 21 gray in one shot. So you have the British delivering 5, the Italian delivering 21. I think probably the optimal dose could lie in between. They published their data recently. Again, local failure rate in the external radiation was 0.4% compared to 4.4% in the intraoperative, which means it's 10 times more. But again, 4.4% is still acceptable. It's less than 5. Usually that's the cutoff line. But what will happen in 10 years? What will happen in 15 years? Will this continue to increase? But they did some subgroup analysis, and they found that if you do a better selection of group of patients, you could do well with the intraoperative radiation. So that's the second technique. The third technique is the 3D conformal. It's not intraoperative. You don't need an extra machine. All what you need to do is just to use your linac. The way how you do the whole breast, you just do a partial breast by using whatever technique, what we call 3D conformal, whether photons alone or photons and electrons or proton, whatever technique you want. And the dose of radiation here was 38.5 gray in 10 fractions in 1 week, more than an afternoon, 6 hours in between. That's how partial breast radiation was described in the beginning. There are different groups will give different doses. Mass General, we give 30 gray in 9 fractions. So now we move into the randomized trial using 3D conformal. The Canadian again took the lead, and they randomized 2,000 patients into, again, very simple, 3D conformal partial breast radiation versus whole breast radiation. And they found that using 3D conformal partial breast radiation, the cosmetic results were poor compared to whole breast radiation. So when they had here cosmetic results assessed by physician or by nurses, 19% poor or fair cosmetic outcome compared to accelerated PBI was 32. So here we start to think a little, was the dose high? Was the technique not that good? Was the dose per fraction high? Maybe they treated more breast tissue than they were supposed to be. Maybe the volume was very high. That there is a lot of debate about that. But this is the fact, a little bit more fibrosis. But the largest randomized trial, which completed accrual, more than 4,000 women, and SABP B39, comparing whole breast radiation versus partial breast radiation. They allowed 3 different techniques, implant, mammocyte, and 3D conformal. And the good thing about them, they included high-risk patients too, because the Canadian included only low-risk patients. Here we had patients with 1 to 3 positive lymph nodes, 3 centimeter invasive lobular. And this trial is not published yet, and expected analysis in 2016. So with 3D conformal, we are still struggling between where do we find this balance between the dose per fraction, the total dose, and the volume. And here comes all the art of radiation in breast cancer. Now, the important thing that was interesting is that when we changed the paradigm from mastectomy into lumpectomy and radiation, at that time, 20 years ago, we had 6 randomized trials, 2 in the US and 4 in Europe, accruing 4,000 women. When we moved from 6 weeks of standard fractionation into hypofractionation, we're still in transit here. We had 3 randomized trials accruing 3,500 patients. Now we are moving from whole breast into partial breast. There are 9 phase 3 randomized trials accruing 14,000 patients. So we expect very solid data once those trials are analyzed.